Good morning, my name is Joshua Rue, and today I'm going to be doing our final health assessment. It will cover the cardiovascular, the respiratory, the abdomen, the bedside neuro, and the peripheral vascular systems. So starting off today, we're going to start with the cardiovascular system. Oh, sorry, we have a clinic dog in today. If my patient could you take off your shirt? Alright, we're going to start by identifying some landmarks. The first one is going to be the suprasternal notch. It is right here around where the clavicle meets, just above the sternum. Next, we're going to look for the angle of Louis, and that will be the sternal angle right around where there's a drop off. Next, I'm going to find the second rib, which will be right around here. And then the second intercostal space between the second and the third rib. All right, and next, I'm going to check for any signs of cardiovascular distress. You feeling any chest pain?
No.
Pain breathing?
No.
You having to use pillows at night to breathe?
No.
All right. Feeling tired?
No.
There's no signs of edema. She's not pale, and there's no blue in her face or on her body, which would be a sign of cyanosis. All right, next if I could have you lay down at a 30 to 45 degree angle.
30. That's
Yes.
okay.
Perfect. And then we're going to check the jugular vein distension. And by doing that, I'm just going to take a look at her neck. There should be some light pulsation, but anything about 4 or 5 centimeters could be a sign of congestive heart failure. And everything is looking as it should. All right, next I'm going to do the hepatojugular reflex, and in order to do that, I am going to press in on the liver at the right upper quadrant a little bit, and then I should see some veins coming. Should see a little bit of vascular distension, and that is normal. All right. Next, I'm going to take a look at the left lower side, around where the apical pulse is, and check for some light pulsation. I should see a little bit, but I should not see any heave or lift, or any sign that that her heart is working too hard. And then I'm going to palpate the apical pulse on the left side using just one finger. Should be right around the 5th intercostal space. All right, then I'm going to palpate over the precordial area with the palmar surface of my hands, feeling for any thrills, which would be vibrations that are different from the normal beating of the heart, and I do not feel any. And for the next part, I will need my stethoscope, which I will grab right now. And I will auscultate using the diaphragm over the areas where you can hear the heart sound the loudest, S1 at the apex or the bottom of the heart, and S2 at the base, or which would be at the top of the heart. All right, and I can hear both of those. And then I'm going to auscultate at the apex of the heart and check for S1 while also feeling for the carotid pulse, and they should coincide. And they do. And next, I'm going to auscultate for the cardiac sounds in the 5 auscultatory areas of the heart, which will be the atrial, the pulmonic, Erb's point, tricuspid, and mitral. So I will be using the diaphragm and the bell for this. So I will start with the atrial, which will be in the right, at about the right sternal border, about the second intercostal space. Next, I will move over to the pulmonic, and then I'll move down to about the third intercostal space to check for Erb's point. Then I will move down to below the sternum, and I will auscultate for the tricuspid. Then I will move over to around the apex of the heart and listen to the mitral. And then I will do the same thing using the bell of my stethoscope. All right, good. And then I will actually have my patient sit up real quick. And then I will auscultate the carotid arteries in 3 areas to check for any roots, and I will be using the bell for that one. So I will start with the angle of the jaw right about here. Then I will move down to the mid-cervical, about in the midline of the neck, and then at the base of the neck. All right. And while I'm auscultating, I will be checking for any systolic or diastolic murmurs. I will be checking for any signs of tachycardia or accelerated heart rate, or for normal sinus rhythm. All right. Now moving on to the respiratory portion of the health exam. I will start with the anterior chest. So first I will check for any signs of respiratory distress. That would be using the trapezius or any other muscles to help with breathing. That would be signs of nasal flaring, pallor, looking pale or looking blue, and having any difficulty speaking. Can you say a sentence for me?
Hi, my name is Caitlin.
Yep, there we go. No signs of distress there. And then I'm going to check the shape and the symmetry of the anterior chest. And to do that, I will do the ratio 2-to-1. Her chest should be 2 of my hands long, and can you lift your arm for me? And from the anterior chest to the posterior chest in the back, it should be 1 hand length long, and that's good. If it was a 1-to-1 ratio, that could be a sign of barrel chest, and that could be a sign of emphysema or COPD. All right. Then I'm going to palpate the anterior chest just to feel for any unusual masses or things that should not be there. Feeling any tenderness?
Nope.
All right, good. All right. And then I'm going to do my patient Caitlin's favorite part and palpate for tactile fremitus, in which I will be putting my hands on a part of her chest and having her either say 99 or blue moon according to the book, and I'll be feeling for vibration, and the vibration should be felt bilaterally. So I'll start over here.
99.
Good.
99.
Good.
99.
Good.
99.
Good.
99.
Good.
99.
Excellent. All right, and then I will be palpating for symmetric expansion, and for me to do that, I will need to put my hands together with my thumbs meeting like this, just below the lungs, and I'll have her breathe in for me, and breathe out. All right, and there was bilateral expansion there. All right, and then I will percuss for lung resonance, and I will be doing that bilaterally. I will start around the sternum, move across, and then move down. So I'll put my finger around here. All right. And then I will put on my stethoscope and I will auscultate over the lung field and check for any normal or adventitious lung sounds, which would be wheezing, rhonchi, or stridor. All right, start on the upper right side. You could take a deep breath in for me. Good. Good. And as I'm doing it, I will be moving across and down across the lung field. In, out. Good. Excellent. Now for the next part, I will be examining the posterior chest, or your back.
You want me to turn around like this?
Yeah, that would be best. All right, and again, I will be checking for signs of respiratory distress using the trapezius, or the sternomastoid muscle, in order to help with breathing. There's no signs there. There's no signs of blue, pallor, or any signs of distress. Then I'm going to once again check the symmetry of the chest wall by again doing the 2 hands across, 1 hand across, and it is a 2-to-1 ratio. And I will palpate posterior chest wall for any unusual masses. Feeling any tenderness?
Nope.
All right, good. And then I will also be testing tactile fremitus on her back as well by doing the same thing. I'll be starting just a little bit to the sides of her scapula. All right. So you can go ahead and say 99.
99.
Good.
99.
Good.
99.
Good.
99.
Excellent.
99.
Good.
99.
Excellent. All right, and I'll be palpating for symmetric expansion. So once again, I'll be putting my hands like this, my thumbs meeting in the middle. Take a deep breath in and out. Good. Symmetric expansion. All right. And then I will be percussing for resonance, comparing the sounds bilaterally. I'll be starting just to the sides of the scapula because if I hit the scapula, it'll give me a different sound. Then I move across and down bilaterally. All right. And next will be auscultation. I'll be once again going across and down all across the lung fields, checking for any adventitious lung sounds or anything that should not be there. So if you could take a deep breath in for me. Good. Deep breath in. Good. Deep breath in. Good. Deep breath in. Good. Good. And normally in a clinical setting, I would not be putting the stethoscope over the sports bra, but for the purposes of this video, I'll just be explaining how I do this. Deep breath in, deep breath in, and deep breath in. All right. And for the next part, I'll be testing for vocal consolidation and using the vocal sound test. And they are egophony, bronchophony, and whispered pectoraliquy. So I will be doing bronchophony and then explain egophony and whispered pectoraliquy. So you could say 99 for me.
99.
Good. And again.
99.
Good. And what I'm looking for in this test is I should not be able to hear. 99 sounds a little bit muffled. If it was clear, that could be a sign of pneumonia or some other serious respiratory issue.
99.
Good.
99.
Good. And for the egophony test, I would be Again, auscultating across her posterior chest wall, and what I would be having her say along E, and if I heard it sound like along A, that would be a sign that there's something wrong there. And for whispered pectoriloquy, be having her whisper 1, 2, 3, and I shouldn't be able to hear it clearly, especially as I move to the peripheral sides of the lungs. If I was able to hear it clearly, that could be a sign that there is something wrong there. And all throughout auscultation, I'll be looking for any adventitious lung sounds like crackling, wheezing, rhonchi, or anything that shouldn't be there. All right, and for the next portion of our exam, we'll be moving on to the peripheral vascular, so you can sit straight for me. Thank you. And I'll start out by checking all the extremities, the arms and legs. You could hold out your arms for me. Good, and turn them over. All right, and there's no signs of scarring or lesions. All right, you can hold out your legs for me. Good. And again, no signs of scarring or lesions, just a little scratches from the dogs, but nothing serious. All right, and I'll be checking for cusps, of course, which would be color, ulceration, swelling, pitting, and scars, and edema as well. And of course, tenderness, turgor, texture, and temperature. All right, and then I will start out by palpating her various pulses bilaterally. So I will start with the temporal right here, just in front of the ear. All right, and I can feel them. Next, I will move to the carotid. I will not palpate these bilaterally at the same time, just because you don't want to pinch off blood flow to the brain. All right. And after I finish doing the carotid pulses, I'll be checking the brachial pulse, so I'll have her hold out her right arm, and I should be feeling it on the medial side. All right, if you could hold out your left arm for me. Good. Then I will be checking the radial pulses, so if you could hold out both arms again. Open, flip them over for me. All right, good. And then I will be checking the femoral pulses. The femoral pulses should be right in the groove, right around the groin area. Good. And then next I'll be checking the popliteal pulse. It should be behind the knee, between the calf and the thigh, and should be right here in the back groove. All right. Excellent. Then I'll be doing the dorsalis pedis pulse, and that should be right lateral to the extensor, or the big toe. All right. And finally, I'll be testing the posterior tibial pulse, and that should be right behind the ankle, or the medial malleus. Awesome. And next I will be doing the Allen test, in which I will be having my patient hold out her arm for me and supinate it. Awesome. And then what I will be doing is I will be pinching the radial and the ulnar arteries. And are you starting to feel a little bit of numbness?
Not really.
Maybe you pinch a little harder?
I guess so.
Yeah, hand is going a little bit white. And then what I will do is I will keep the radial artery pinched, but then I will lift my hand off the ulnar artery and start to get some feeling back to your hand.
Sure.
Yeah, make a fist for me. All right, good. Yeah, and the color is starting to come back. What I'm testing for is If I still had the radial artery pinched, but her hand was still numb or there's still no color to it, there could be something blocking the ulnar artery, and that could be a major issue. And for the final test, I'll be testing capillary refill. So I will have you hold out your hand for me. I'll push down a little bit on her nail and then see how long it takes to refill, and it refilled within a couple seconds. Same thing on this hand. All right, and it refilled. Then I'll be doing the same with your toe. Yep, and pretty much instantaneous. Good. And what I'm looking for there, if it's delayed regaining its color, that could be a sign that there's something wrong, or with peripheral vasoconstriction, or there's the blood is not getting to the peripheral regions as it should. All right, and that concludes the assessment of the peripheral vascular system. Next, we'll be moving on to the bedside neuro exam. For this one, I'll have you lie down again, like you would be in a hospital bed. All right, first I'll begin by testing her level of consciousness. First, I will see if she is alert. And in this case, she is. Her eyes are open. She looks like she is fully responsive. She's looking around. If she was only responsive whenever I called her name, that would be verbal. So for example, if her eyes are closed, say Caitlin, and she opens her eyes, she would be responsive verbally, and she could be able to follow commands. All right, and for pain, it would be if her eyes were closed, I tried calling her name, but she didn't answer, and then I had to do something like either rub my knuckles on her sternum or pinch her earlobe in order for her to wake up. And unresponsive would be if I walked into the room, she had her eyes closed, she didn't respond to her name, and she didn't respond to any pain. She would be considered unresponsive. Next, I will check orientation, and I'll start by asking, what is your name?
Caitlin.
All right, what is your occupation?
Teacher.
Awesome, and how old are you?
I'm 24.
Excellent. And then I will test by asking her where she is right now, or what's her location. Do you know where you are right now?
My house.
Yep, or the hospital. Do you know what city you're in?
Louisville.
And what state?
Kentucky.
Awesome. And then I would check to see if she knows what time it is, not only just like what actual time it is, but the day, the month, and the year. So do you know what today is?
Is it like June 18th?
Yeah, June 18th,
Okay.
or it could be Thursday, yeah.
Oh, okay.
Do you know what month it is?
June.
And do you know what year it is?
2020.
Awesome, so yeah, she is responsive there. All right, next I'm going to be testing her motor response. And for that, I'm going to hold out my 2 fingers, and I'm going to have her make a fist around my 2 fingers. And and if she makes a fist tight enough, I shouldn't be able to move my fingers out. And that is good. And next, I'm going to test her leg, in which I am going to push down on her thigh and have her lift against my resistance. All right, good, and that is a good reaction. Next, I'm going to test her sensory function, and I'm going to test for superficial touch and for superficial pain. And for the process of superficial touch, I will be taking a cotton ball. I'll be having her close her eyes, and I'll be applying it to various parts on her body. And whenever she feels a sensation, I'll have her say now, and I will be applying it bilaterally to see if she feels it all across her body. All right. If you close your eyes for me, let me know when you feel the cotton ball.
Now. Now.
Good.
Now. Now.
Good.
Now. Now.
Good. And for the next test, I'm going to be testing superficial pain. And for that one, I will be using both a cotton ball and, for the purposes of this video, a Q-tip. And what I'll be doing is I'll either be applying the cotton ball or the Q-tip. And if she feels the cotton ball, she will say soft, but if she feels a Q-tip, she will say hard. And I'll just be switching off bilaterally across the body and seeing how she responds to that.
Hard.
Yep.
Soft.
Yep.
Hard.
Yep.
Soft.
Yep.
Hard. Hard. Soft. Soft.
Excellent. And next I will do the Perla test, in which I will be taking a look at her eyes. First I'll be looking at her pupils, making sure they're symmetrical, making sure they're equal in size. And they are looking good there. Next I'm going to take my pen light. And I'm going to shine the light in both of her eyes and watch the pupils constrict. Good. And then I'll have her just take a look out beyond at a distant object. And her pupils should dilate. And then I will move my finger close and have her take a look at that, and as I get closer, her eyes should come together and her pupils should dilate, and they do, and that is accommodation. And that completes the bedside neuro examination. Then we move on to our final health assessment of today, and that is the abdomen. So if I could have you sit up for me real quick. Thank you. All right, so we're gonna start out by dividing the abdomen into 4 quadrants. So we'll just kind of do like this with the umbilicus in the middle. All right, so this is the right upper quadrant, this is the left upper quadrant, the left lower quadrant, and the right lower quadrant. All right, and I'm just gonna begin with a basic inspection, checking the color, making sure it's a healthy pink color. There's no odd lesions. There's no signs of drainage. Taking a look at the belly button, yeah, no drainage, no swelling around there. And I'll be taking a look for caput medusa. That mostly is for pregnant women. It is the venous pattern around the umbilicus. And again, that's usually women who are pregnant or have been pregnant. And just any signs of herniation. So I'll have you cough for me. Yep, no signs of herniation there. All right, if I could have you lay down for me. All right, next we will switch it up and we will begin with auscultation before palpation. And the reason why is if we begin percussion or palpation of the abdomen before we auscultate, it could increase peristalsis and give us false bowel movement sounds. So I'm going to check for bowel sounds, and I'm going to begin in the right lower quadrant. All right, and once I hear it, I'll move to the right upper quadrant. Then the left upper quadrant. Then the left lower quadrant. All right, I heard those within about 5 to 15 seconds. In order to mark bowel sounds as completely absent, I would have to listen for 5 minutes in each quadrant. And if after 5 minutes I had not heard a bowel sound, I could mark them as absent. All right, and next I'm going to auscultate for Brutes at the for Brutes in the following arteries: the aorta, the iliac, the renal, and the femoral. So for the aorta, I will start a little bit above the umbilicus, and again, I'm using the bell of my stethoscope. And I'm looking for any abnormal whooshing sounds. I don't hear any. Then I will kind of go lateral on the left side to the, after auscultating the aorta, I will move little bit lateral, left lateral to the umbilicus for the renal, then a little bit lower than that for the iliac. Then I'll move to the groin region for the femoral. All right. Then I would percuss the abdomen for any abnormal masses or excess air, and I'll be doing that in all 4 quadrants. All right, everything is looking good. And then I will palpate the abdomen. I will start with very light palpation, just a few centimeters. And then I will do a little bit deeper palpation, about 4 to 5 centimeters. All right. And then I will palpate, I will percuss. I did this out of order. I will percuss, checking for liver span. All right, I'll start a little bit above the ribs and continue to feel a little bit of dullness. The liver should only extend a few centimeters beyond the lower edge of the ribs. I'll move over to the left side and percuss for the spleen. And I should really not be able to percuss the spleen. The spleen should be completely under the ribs. If I can, it is a sign of splenomegaly and something that would need to be checked out. All right, then I will palpate the liver by doing that. It's my left arm underneath her back. Then I will kind of hook my fingers. I should be able to feel the liver right there. Next, I will put my left arm over or under her back here. Also, and feel from an angle, and I should be able to feel the spleen. And then I'll have you sit up for me. All right, and I should go just at the costovertebral angle, just underneath. I'll kind of feel in her back, and I should be able to palpate the kidneys, and then on the other side. Good, and then next I'll be feeling the inguinal nodes. There are horizontal and vertical inguinal nodes around the groin and the upper thigh region. The horizontal slant towards the groin here, and then the vertical kind of go down the leg, here. All right, and next I'll have you lay down again. And then I'll hook my fingers over. I'll be testing for diastasis recti, or it would be when the abdomen is torn. So I'll feel down the midline and just have you do a crunch for me. All right, good. And there looks as though the abdomen is together. There's no sign of separation. Next, I'll have you sit up for me. All right, and if you turn your back a little bit towards camera, good. Then I'm going to do the costovertebral test for costovertebral tenderness. And by doing this, I will be putting my hand on her back like this, and then kind of doing a light bump. Any tenderness?
No.
All right. And a light bump. Any tenderness?
No.
And this is checking for inflamed kidneys, because if she had any issues like pyelonephritis, she'd be screaming. All right. And while I'm also auscultating for bowel sounds, I'll be checking for hypoactive bowel sounds, which, as I mentioned, if I did not hear any bowel sounds for 5 minutes, it would be hyperactive or hyperactive or borborygmi, in which there's a lot of gurgling and a lot of gurgling sounds heard. All right, and that concludes today's health assessment. Thank you so much.